Hi, I'm Scott Benson. I'm a child psychiatrist. I practice in Pensacola, Florida. I've practiced in Pensacola, Florida since 1976. In that role, I've had a lot of opportunities to work not only in my practice, but to work with agencies in the state of Florida. And I've been called on to participate in a lot of roundtables and workshops trying to look at the problems that we have for children who are in dependency, whether and what kind of help and support they need, and particularly what kind of help do they need as far as psychiatric treatment is concerned. Certainly we all hear the kind of really astounding statistics about the number of children in foster care, which always is upsetting, depressing, but we're glad that they have safety and that they're going to get some care. But we're concerned about the level, amount of mental illness kind of problems that they have, the level of behavior disturbance. And a lot of research has been done on that. I don't think anybody has the answer. But because of the problems that they're having, often they're referred for treatment. And what I want to talk about today is exactly what that treatment looks like, how we would understand that treatment, what's the role of a psychiatrist in providing that treatment, and particularly I want to talk about a big concern that we have is what is the role of medication that we might use for treating a psychiatric condition. To help you, point you to some resources, I want to alert you to the work of the American Academy of Child and Adolescent Psychiatry. That's the National Organization of Child Psychiatrists, and at the Academy of Child Psychiatrists we have it's called a Committee on Quality Issues, and I've been privileged to serve on that committee for about 15 years. That committee has the responsibility of writing what we term as practice parameters, and these are the guidelines that physicians would use physicians and other professionals would use in evaluating children arriving at a diagnosis, developing a treatment plan, and what would be the appropriate treatments. And we develop these practice parameters by considering what is the science, what science do we have today, and where there's not science, we try to gather information from experts and come up with a clinical consensus. Because medicine, or psychiatry, like all fields in medicine, really is practicing without the kind of hard science that we would like to have. We keep pressing and hoping that we're going to get closer. But there are some things that we know based on the kind of scientific research that we're able to do. So the first thing I want to do, though, is to really thank you for taking time to view this video and to learn this information and to volunteer as a guardian in helping the children of Florida. It's a terrific service that you're providing. Certainly that's something that children need. So let me start with kind of the way I would start with parents that I often meet in my practice, and what I talk about as I start talking about brains. So it's good to understand that your brain is 100 billion nerve cells, that all those nerve cells are connected to each other. Each nerve cell, in fact, is connected to about 10,000 other nerve cells. For purposes of our discussion, and this probably isn't true, and some of my scientific colleagues would argue with me or yell at me for even suggesting this, but what I like to talk about is the idea that groups of nerves clump together, and so they all have a different kind of job or responsibility. So it's fun. We like to think that our thinking nerves are up in the front of your head, which is why when you scratch your head you always get some really brilliant thoughts. In other parts of your brain, you have a set of nerves that controls different sides of your body, and people understand that because they've known people who've been tragically injured in a stroke, and so they might be paralyzed on one side or the other. And also in neurology, we can kind of pinpoint, and they're often very specific small strokes where people forget certain things like the name of an object or the name of a person, but seem to be able to be clear and remember other things. So it helps us understand that the parts of your brain have very specific small functions. So if we consider that the front of your brain is where you do your thinking, then kind of down in the middle of your brain is where I like to talk about the idea that's where your feelings are. So your feelings would be down kind of low in your brain, because we know that very young children have really intense feelings, and if you take away their pacifier, or you stick them with a pin when you're pinning up, well, I guess people don't pin up diapers anymore, but Uh, but when you do something to them, you can see the feelings that they have. So they have that capacity in their brain. Now, so what happens then in psychiatry is that we talk a lot about the connections between your thinking brain and your feeling brain. And we have a lot of common expressions that we use when we're kind of thinking that way. We talk to people and a person that's really upset, and we say to them, you need to get a grip on yourself. Well, it's kind of fun to think about what happens in your brain when you're getting a grip on yourself. Well, the way I like to think about it is that you're using your thinking brain and little connector nerves that connect down to your feeling brain. And so you use those connector nerves after you've decided that this thing, whatever it was, wasn't worth getting that upset about. You use those connector nerves to shut down the feeling, because the feelings have already started into full action. If somebody told you something sad, you've gotten that tightness in your chest and lump in your throat and tears in your eyes. And that all becomes because your brain has thought a sad thing, activated your sad nerves, and is generating a sad feeling. Same way with anxiety or scared feelings. So your muscles get tense, your palms get sweaty, your mouth gets dry, your eyeballs get real big, and so that would be anxiety. And most of the time, the thing that you're anxious about or sad about is easy to see. And if you told it to somebody else, if you say, I got up this morning and my dog ran away and I can't find him anywhere and I'm really sad, they understand exactly what you're talking about. They understand that the amount of sadness that you're feeling is about the size of how important that dog was to you. So we can generate a lot of feeling related to whatever it is that we're thinking about. Now, in children, what becomes clear is that their ability, the amount of thinking brain that they have, if you will, to kind of think through a problem is limited. They're just not. They don't know as much as, well, I hope we all know a whole lot, and the children don't know very much. So our ability to understand the world as adults has a different level of thought or cognition, if you will, that goes into it. So we can think about things as a grown-up would think about things. And we say that to children, why don't you grow up and act like a 7-year-old, somehow that a 7-year-old is supposed to act a lot better than a 3-year-old. But when you think about the kind of stress that a child might go through, then you have to think about, well, how would they wrap their brain around, how would they think about that kind of stress? What does it mean to them? A really good example that always I think is helpful for people is we have to remember that because developmentally all very young children idealize their parents. Fortunately for all of us who have been parents, our children couldn't see all of our flaws and our warts because they simply have to be blind to that. So even in children who've been abused, no matter how horribly their parents have treated them, what you're going to find, and it'll always be puzzling, but what you'll find is that child still is deeply in love with their parent and has totally overlooked all of the things that we know as grown-ups are harmful and dangerous for that child. So don't be surprised when little children are really angry that you took them away from their parents, even though we took them away because of the kind of mistreatment that they were suffering. So as I think, if something happens and it stresses me, then I have to be able to get into my thinking brain and I have to be able to think about what that is. I have to control my feelings so I don't get into that state where I am so upset I can't think straight, which is another favorite expression of mine. That I was so upset I couldn't think straight. Some of us have been there, hopefully not too often, that we're able to keep our wits about us. I like all of these common expressions because they help us explain a lot of what we're trying to accomplish. But these children that you're going to be working with and that you've met have been through a lot of stress. They've been through a lot of stress before they came into care. Coming into care is horribly stressful, overwhelming, and confusing to them, and they don't really understand what it is that that's happened and why they're in the situation that they are. And that we're sort of asking them to suddenly move to a new house, just kind of move in and settle in, and just sort of pretend that it's all home, and we're asking them not to spend very much time worrying about their family that they left or what's happening to them, and often all of that gets really mixed up in a huge conundrum of problems for these children, the kind of problems that I think all of us have a hard time wrapping our brain around. Now, so if we take that little bit of brain instruction, and I didn't want to spend too much time on the neurobiology of it, but the idea is that we use our thinking brain to stay in control of our feelings, that things will happen and we become aware of those things that will upset our feelings. Our job is to stay calm, kind of think our way through the problem and come up with a good solution. Now, so in children who come into foster care, many of them are suffering from those kind of conditions. But there's another group of children who are suffering from what in psychiatry we would term kind of brain problems, if you will, or brain conditions. And this is another set of kind of psychiatric sort of problems. The most common of that problem is attention deficit hyperactivity disorder. Most people would think of that as the hyperactive children who might be treated with Ritalin or other medication, other stimulant medication that has been shown to be very effective. The thing that's important to remember is that if I take a child and I make that child very anxious for whatever reason, so if I march two strangers into their classroom and I haul their teacher out screaming, and this other person comes in a horrible looking uniform and says, "I'm in charge here," all of those children are going to be terribly anxious, and because of their anxiety and the scared feelings that they're having in their system, they're not going to be able to concentrate and focus. So children who have high levels of anxiety are not able to concentrate and focus. But there's a group of children who don't have those high levels of anxiety, and when we look at behaviors that they have and look at challenges that we give them to focus on some academic task, we realize they can't concentrate or focus at all. Now, so that condition is attention deficit hyperactivity disorder. For those of you who are interested, I would encourage you to get a copy of the Vanderbilt rating scale, because that rating scale lists all of the symptoms that we might see in children who have attention deficit hyperactivity disorder. It doesn't tell you that's what they have, but it kind of sorts out the symptoms so that you can see this child has inattention problems, another child has more hyperactive problems. So in a child who has, and I'm just calling it ADHD, and people sometimes are confused. They think that ADD, attention deficit disorder, is somehow different from attention deficit hyperactivity disorder. They really are the same. They're treated the same. The evaluation is the same. So many of the children that you meet are going, or some of the children you meet will have been evaluated, and they might have a diagnosis of attention deficit hyperactivity disorder. So what happens in ADD is that we learned what happens in ADD not by studying people who have short attention spans and are unfocused, but we learn it by studying people who have long attention spans, who are really boring, like I'm kind of boring. And so but they have a very long attention span. Now, it's easy to see that if you have a long attention span, that's going to help you in school. If you have a little tiny short attention span, you're going to have trouble in school. But people are born, and we know that this happens, people are born with an attention span, and some people are fortunate, at least in our academic world, and they have a long attention span. Some people have a little struggle because they have a short attention span. The condition typically runs in families. It's common, and we're seeing it more and more in my practice, where I'm meeting parents who, as children themselves, had a diagnosis of ADHD, and they took medicine and they remember how it helped them. They see the same symptoms in their children. They're ready to start looking at whether medicine would help their child. So what happens with those, or what happens in that condition is, and we can show this in brain scans of teenagers who some have ADHD, some do not have ADHD, and when you give them a focused task, we can do a certain kind of brain scan and show that the ones that do not have ADHD use certain parts of their brain that just don't show up in the ones who do have ADHD. And it has nothing to do with intelligence or whether you have a good heart or whether you really want to be a good person. It has to do with whether you can stay focused on what your plan was. So in the kids who have ADHD, if we pick the right medicine, and all of the medicines seem to work very well. They've all been studied by the FDA, so we know that they all will work about the same. So if we have them on the right medicine, so they take their medicine 20 or 30 minutes, the medicine starts working and their concentration and focus is improved. And then what you get to do then is you get to see the kind of heart of this person, because now they're able to be the person they were planning to be. And after a while, the medicine wears off. So during the time they're on medicine, there's nothing permanent that changes. It's just that it helps them, kind of the way that my eyeglasses help me. Now, if I go swimming, I don't need to wear my glasses because I can do that without my glasses on. But if I'm going to be reading some really boring medical book or something, I really need to have my glasses so that I can see it and understand what I'm trying to learn. So in children who are evaluated carefully, and the evaluation requires that they're seen by a doctor, you want to make sure that they can see well, hear well, that that they don't have some other condition like one of the anxiety problems that I mentioned earlier, and that you do a Vanderbilt rating scale or some similar rating instrument that says, yes, this child's having a lot of trouble, and these are where the problems are, and this is the trouble they're having in the classroom. And then the next part of the assessment, it's kind of after the assessment, but you make a decision about medicine, and then you try the medicine, and you're looking to say, okay, what helpful effects did the medicine have? Did it help with the target symptoms? And I'm going to talk a little bit about target symptoms, because in my psychiatric business, I don't have a thermometer or a blood pressure. I can do your blood pressure, but that's not going to help me understand about your ADHD. So what I always get parents and kids to do is I get them to tell me what behavior needs to get better. What is it that you want to see improve? And then we measure that behavior. You can't just globally, and we've had good science on this, it doesn't help to just globally say, oh, well, let's see if he gets better or not, or even to look at grades, because grades has so many other aspects that are involved. But you're really looking at their ability to stay on task, their ability to get along with other people, their ability to control their impulsivity. Usually in young school-age children, that impulsivity is usually seen in terms of them being sassy, back-talking, those kind of quick impulsive responses when you're trying to talk to them. But to see can they stay on task and get assignments done. So if you see that, if those were your target symptoms, then when I have the families come back to my office, what I'm asking them about is, did we see improvement with the target symptoms that we picked? Are there any side effects? So we're always trying to balance against helpful effects and side effects. And if we're really being good doctors, the helpful effects always win. The helpful effects always have to be stronger than any kind of side effects that we might be worried about or looking at. So that's kind of an example of a psychiatric condition where attention deficit disorder with the kind of typical symptoms it would have, that the doctor evaluating that child is going to come to that kind of conclusion, and a decision is made that based on that pattern of symptoms, medicine treatment might help, and if the medicine treatment is helping, it's going to help these target symptoms, and that we're going to try the medicine, and that we're going to go on and then measure the target symptoms and see how it works out. But when we're talking about attention deficit hyperactivity disorder, I'm going to anticipate that you have some questions and some things that you've heard that you might want to ask a little bit more about. So I'm just going to go ahead and answer those, because when I do talks about ADHD, people often ask me, number one, well, doctor, isn't it just that these children are watching too much TV and too many video games? Well, the answer to that is twofold. One, yes, children are watching too much TV and playing too many video games, and my biggest concern as a physician is the more TV you watch, the fatter you're going to be, and we've already got too much obesity in our nation, and so I always encourage families that I'm working with to really put some limits on how much TV time we're going to have. One of the families that I had in my practice would get the TV guide on Sunday, and they would go through and mark out exactly what were the programs they really needed to see that week, and the rest of the time they left the TV off. And many families just leave it off during the week because it's just too attractive to children. The next thing that people ask me, they said, well, it's these terrible diets, and it's all the sugar and food additives and bad stuff that you get. And my answer to that is I'm really concerned about the kind of things that we eat in America today. And again, it goes back to the obesity problem. As far as the sugar problem, our science, as we've looked at it and looked at the effect that sugar has on children's behavior, our science just doesn't show that it makes much of a difference. On the other hand, your dentist is really concerned about sugar and really would like for you to really limit the amount of sugar that children eat. And so if you have strong feelings about sugar, and I've met families that have told me that they saw great changes in their child's behavior when they limited sugar, I applaud them. That's a real simple thing to do, and it's good for the rest of their health. And also, the people will say, well, it's because we don't have any exercise time or recess time at school, and that when they get home they have so much homework and they need to get out and get exercise. And again, I'm all for that. But again, when it truly is a child who has attention deficit hyperactivity disorder, it isn't just exercise or sugar or their diet or video games. The other thing that people will tell me, and I want to make this as really more of a general comment, when I sit in my office, of course, I'm most often talking to parents, and they'll come and they'll tell me, you know, teachers just aren't any good these days. They're just there for the money, and they don't know the children, and blah, 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 blah. And I try to tone that down a little bit, because when I go to the schools, I sit with the teachers and the principals and guidance counselors, and they say, you know, the parents just aren't they aren't what they used to be, and they aren't cracked up. And then I remember that, well, my mother was a teacher, and she cracked me up a few times in all kinds of different ways. But so I think the teachers are really good, and I think the parents are good, and I think that parents do the very best that they can under the circumstances that they have, and that often they get overwhelmed either by illness or the circumstances that they're in, and often the state has to step in and take care of their children. I always approach this in my work in this whole field with the idea that these parents are really trying to work hard, really trying to make the world better for their children and trying to keep their family together, and that all of my work needs to be in the direction of supporting them. So we've talked about ADHD and medicines for ADHD, and I picked that one because that's the most common kind of psychiatric condition that you're going to see as you're working with these children. And I say that because that's the most common psychiatric condition that we have in any population of children. We get into another group of children that are going to have problems with anxiety. They're going to have problems with depression. They may have suffered some terrible trauma and have a pattern of symptoms that would fit with post-traumatic stress disorder. They may have more serious psychiatric conditions. They certainly can have schizophrenia and bipolar disorder. The thing we need to remember first is that those conditions are extremely rare. So the fact that these children have come into care shouldn't give them a higher prevalence or a greater number of those kind of serious psychiatric conditions. And because of that, there's been concern about the amount of that so many children in foster care end up on some kind of medicine. To my thinking, and I don't have a lot of good research to back this up, some of the things that I've read, and in fact the Academy has a practice guideline on children in foster care, but some of the things I read says that these children are really reacting to the stress of the tumultuousness of their environment, and that if we get them into a stable, dependable, reliable situation where they have a go to bed time, a get up in the morning time, breakfast time, lunch time, dinner time, time to do your homework, and that kind of, here's where your shoes are going to be, here's the clothes you're going to wear tomorrow, and having that kind of predictability really solves a lot of the anxiety and depression and sadness that these children have been feeling. Sometimes the emotionality of all of their troubles, if you will, is overwhelming to them, and they may have some kind of behavior disturbance. And then then there seems to be a tendency, and I think the part of the legislature's concern in this, it reflects the idea that we start using psychiatric medications in the way that we would think of tranquilizers. So now a tranquilizer, of course, is something that is going to make you feel better about a very difficult situation. A very common situation where in my work I might prescribe a tranquilizer is I meet a few people who have to travel with their work from time to time, and they just get terrified on airplanes. Now, they don't travel often enough that they need to go to all the trouble to learn how to love airplanes, but they do travel often enough that I need to find some way to help them feel better when they're getting on an airplane. And I do have some really good medicines that can help them feel better when they're getting on an airplane, even though in their mind, in their thinking brain, they're terrified. I can get their feeling brain just to be oh so calm and quiet. Same way with going, often people tell me they can't go to a dentist because just the idea of sitting there with their mouth open is terrifying. Well, often dentists will prescribe tranquilizers, Valium, Librium, Xanax, medicines like that to calm people down. Well, we know that those tranquilizers work real well, and so then we kind of segue, we kind of move into other psychiatric medicines, and we say, well, if a child is really sad, then isn't that depression, and shouldn't an antidepressant make them feel a little happier instead of being so sad all the time? And the answer is no. No, do not give sad people, if that's their problem, if something terrible happened and you are terribly sad and you have to go to a funeral and you're feeling terribly sad and crying, do not believe for a minute that there's some medicine that's going to make you feel better, that this person who was important to you died. You are not going to feel better. It will do something to you. In fact, the research shows that in people who are grieving and worried and struggling with a loss, if they take medicine, it makes that problem with that loss worse. So we have a real responsibility then to be sure that we aren't treating unexpected sadness. So if I got removed from my parents last week and I am sad about that and I haven't heard from them, or I did hear from them and one or more of them is in jail and I haven't seen my brother lately, then of course I'm going to be sad. And but it doesn't mean we don't do any treatment, because we have good talking, psychotherapies, counseling, supportive treatments that help children through those very difficult times. And that we're learning more and more about how to help children through trauma. One of the best resources for people that are interested in that whole area is to go to the National Children's Trauma Network. They have a terrific website with a lot of information that's geared to every level. And in fact, they have little courses that people can take on how to really help children who've been traumatized and help them talk through it and think about it. It's not a medicine problem, it's a talking problem. And one of the challenges for me as a psychiatrist is when I meet a person, I have to make some pretty quick decisions and decide, does this person have a medicine problem, or is this something that we need to be talking about? And I've had people come to me and they say, I'm a little bit sad, could I have a little bit of an antidepressant? And the answer is no. Because a little bit, if you have depression, and there is a real problem with depression, and there are people who are horribly, deeply black hole, crying, miserable, depressed, wringing their hands, thinking of suicide, and that is a very serious condition, and the treatment of choice for that condition are medicines that we term as antidepressants. And if you're going to take those medicines, if you have that kind of condition, you have to take enough. You don't take a little bit for a little bit of sadness. If you have depression, you take enough. And the other key and a really important kind of treatment planning thing is if a doctor decides, well, this is depression, it should get better with medicine, then the research says if it's going to get better with medicine, it will be better in about 6 weeks. The research also says if it's going to get better with talking, with therapy, counseling, it will get better in about 6 weeks. And if somebody's having that much trouble and they're not getting better, then they're on the wrong kind of treatment. So I want to steer people away from the idea of thinking about these medications as tranquilizers. We really need to think about them as powerful treatments for very serious psychiatric conditions. You arrive at the idea that this is a serious psychiatric condition by doing a very good, thorough, detailed psychiatric evaluation. for the children that you're going to come in contact with, a majority of them, or all, if not all of them, should have what's known as a comprehensive assessment, which is a very detailed history of all of the medical and psychiatric problems that they've had before, a lot of background information about their families. That information is very helpful to me as a psychiatrist if I'm doing a full assessment. And that there need to be symptom patterns that meet the diagnosis. So you have to justify using medication, you have to come to a diagnosis. The doctor prescribing the medication has to make a diagnosis. And that you'll see these things when you look at, there's a set of forms, because again, what the legislature was very concerned, and not just the legislature, people all over the state were concerned about getting at good expert psychiatric care to children that have, through no fault of their own, have come into state, come to the attention of the state and are now in state custody. Because what happens is that if you have your children at home and your child is not old enough to give consent, so consent is being able to listen to the information the doctor has to say, understand the condition, understand the various treatments that are available for that condition, and you have all of this information, you can process that information and come to a good conclusion for you, because your own values are weighed in there, and you give consent for a particular kind of treatment. So since children can't think that well, supposedly, now as a child psychiatrist, I think they think a lot better than we give them credit for, but anyways, for children, they're not allowed to give consent. So you reach the age of consent, usually 18, I think, is the legal age of consent. So parents give consent up to that time. For certain medical things, younger children can give consent. Now, so since the parents of these children may not be available, or because of the situation that's come up, their parental rights have been terminated, then what has to happen is you can't just let the doctor just do whatever they want, and we aren't going to put that burden on foster parents. So we've set up this legal process by which a judge is asked to consider information, and the judge then would authorize, so the key word there is authorize, some kind of treatment. One of the things the judge is going to consider, one of the things that a doctor, or a psychiatrist in this case, would be considering, is that you would look for the child to give assent. That's A-S-S-E-N-T. So a child says, I'm either really interested in trying this, and I understand how it's going to help me. He can't really give consent, but he can give assent. So the treatment's going to go much better if, as a physician, I have explained it to that child as to exactly what we're going to do, and I get a statement of agreement. It's not uncommon in my practice that I meet an unruly, grouchy middle school student who's already arguing with his parents over everything, and they brought that child to me, and it looks like that maybe some medicine might help. But if I can't work with that child to get them to agree to take the medicine, and I write a prescription and give it to the parents, I've just picked another fight for these people to go home and fight with this child whether he's going to take the medicine or not. And what I learned as a doctor a long time ago is I can write have a very well written prescription with just the right medicine and the right dose and the right instructions and the right amount, and get it to the right pharmacy and get it to their house and put it on the kitchen counter, and if somebody doesn't take that medicine, it will not do them any good. So getting assent from children is going to be very important. And I think that's a role that you can help with if you have time and you've developed a relationship with that child. Not so much that you have a job to talk them into anything, but you can help them kind of think through and kind of listen to some of their concerns if someone has recommended that they take medicine and they just aren't sure yet. So the process that happens is that the child has seen a physician, a nurse, a pediatrician, a number of people who are authorized to prescribe medicine. Based on the condition they have, they've arrived at a diagnosis. Based on that diagnosis, we're going to recommend some kind of medicine. They would write a prescription for that medicine, and then they start filling out forms, and because they've got to get information back to many people. And a lot of those forms will get to the court. One of the forms is going to come and there's kind of a second opinion. It's not like seeing the child and doing a full evaluation, but what the court has asked is could we get another psychiatrist to take a look at this, at the records of this particular child or some part of the records. What's the condition, what's the recommendation of medicine, and does it make sense to that child psychiatrist? I was asked many years ago by the guardian ad litems in District 1 to help with that process. So I often am reviewing children's records, looking at the condition they have and the medication that's being prescribed. And it's usually a very collegial kind of thing, and then I look at that report, get it back, and that goes to the judge and helps the judge in terms of the decision that they need to make. They're looking for support on that side. They're looking for clear assent from the child, and they're looking for a pretty straightforward kind of medical situation. So let's talk a little bit more about some of the other conditions that you might see in your work with some of the children that you might be involved with. Another common diagnosis that you might see would be depression. And I spoke earlier about people who really have deep, black, dark depression with terrible crying spells. Nothing's fun anymore. They can't function in school anymore, and they are sad all the time. So they have to have a pervasive mood of sadness. So we know that in children who meet the criteria for that diagnosis, we know that medication works for the children, but it works for the children who have that kind of serious depression. For children who are sad, it's real clear in our practice guidelines that we ought to do some kind of therapy first to help them figure out how to control that sadness, how to improve their ability to control that sadness and give them a different perspective. One of the little stories I always like to talk about is, in terms of treatment, is talking about the preschool work that was done in helping children develop play plans. So we often talk, and we don't do this very much with children, but the idea of getting them to plan ahead about what they're going to do. And in this particular study, they had a bunch of children, fourth grade preschool program, and they would send them out, recess time would come at 10:35, and they would send them out to the playground, and as you can expect, in about 10 minutes they were throwing sand at each other, chasing each other around, screaming, pulling hair, and the teacher had to go intervene with a number of them. So they had another group of kids, and what they asked this group of children to do, they said, in a few minutes we're going to go out on the playground, and before we go out there, I want you to think about what you're going to do on the playground, and I want you to draw a picture of yourself doing that. And of course these children were very cooperative, and they sat there with their crayons and their paper, and they drew pictures of little children hanging on the jungle gym, or building sand castles in the sandbox, or playing kickball with a couple of their other friends. And when those children planned ahead and they went out onto the playground, they played pretty pleasantly together for about 35 minutes. So a lot of what we do in therapy, and you'll hear maybe in your work or other places, or I would encourage you to look at some research on what we call cognitive behavioral therapy, which is just helping people think about how do you want to feel and think about how you're going to conduct yourself in the next time frame. I have a lot of parents who tell me my child is miserable. He gets in the car and starts telling me about all the bad things that happened in school that day, and my instruction to them is to first tell them I really want to hear the bad things that happened, because I know that's important. But before you tell me all the bad things that happened, could you tell me two things that happened that were really nice, where a child went out of their way to help somebody else, or sometime that the teacher helped somebody learn something? And they'll say, and what really gets fun to do is the kids, nobody did anything nice, and then you get to look at them and say, well, that includes you? So let's think of what nice thing you're going to do tomorrow, and so you catch them at their own game, So I'm mean that way, but it gets to be kind of fun. But that kind of helping children to think about how they're acting, to think about how they feel, and they catch on to that. They understand how to do that, and often it improves just the overall function of the whole situation. And you don't end up having to go get a big diagnosis or have children get on a bunch of medicine. The other group of children that you might see are children that have anxiety problems. The biggest group of that are children that are going to have post-traumatic stress disorder, and many of the children you see will have been through some kind of pretty horrific situations, and a situation that would, so there are many things that are traumatic. I met a child and or a family, and they were trying to tell me that their child's broken arm was trauma, and he still thought about how he broke his arm, so he had post-traumatic stress disorder. Well, breaking your arm is not trauma. I mean, if someone comes up and grabs you and beats you half to death, and in the process you get a broken arm, that would be pretty traumatic. But just falling off a swing and breaking your arm really wouldn't be what a psychiatrist would consider as trauma. And even if you're upset after that, it doesn't really count. But children may have a diagnosis of post-traumatic stress disorder, and our research is very clear on post-traumatic stress disorder. Counseling therapy is far and away the best treatment. Medicine plays a very small, if any, role at all. So we need to be, I would always kind of raise my eyes if somebody has that diagnosis and someone's trying to give them medicine. I'm really looking at what is the therapy that's being provided, and you can be strong advocates for the therapy that these children need. Some of the children may have very serious psychiatric conditions like schizophrenia. That's going to be very rare, and I doubt that I doubt that any of you, I hope that, I just don't think you're going to see that kind of condition. You may see children that have a diagnosis of bipolar disorder. We have to be real careful about that. Sometimes we've had a problem, I think, in child psychiatry because we've taken an adult condition. We've known about bipolar disorder for 200 of years, so we know what that looks like in grown-ups. Now, what happened is we realized, well, this seems to be a brain problem. It seems to be inherited. What does bipolar disorder look like in children? Well, so we start doing the research. So you find families that have bipolar disorder that runs in the family, and you look at their children's behavior, and you can find bipolar disorder in children, and they have some really erratic kind of mood swing, off the wall kind of behavior. But it still is a very rare condition. Unfortunately, children who have erratic behavior is not an uncommon condition. So there's a whole bunch of children who have erratic behavior, but the erratic behavior itself doesn't give me a diagnosis of bipolar disorder. But there's been a tendency to try to treat the children with erratic behavior with medicines that might be helpful for children with bipolar disorder. And my response is if it's working, great. But if it's not working, we really need to look at the other things that we ought to be doing, and that would come back to the therapy, counseling, the kind of parent training that the foster parents would have had. Those kind of things really can make a difference in terms of helping children control their erratic behavior. But if somebody tells me a child has bipolar disorder, typically they'll say, well, my child has mood swings, and I'll say, well, they swing from what to what? And they'll say, well, sometimes he's really happy and sometimes he's mad. Well, tell me about the last time he was mad. Well, last night he was really mad. I went in and told him it was time to turn off the TV and go to bed, and he just had a huge, big temper tantrum. Okay, that's not bipolar disorder. That's just a huge, big temper tantrum. And we, again, you come back to the kind of cognitive behavioral therapy and good parent training. We have ways to help children who have those kind of problems without doing, it's not a punishment thing. You know, I tell parents, stop thinking punishment. Don't think about punishment. What I want you to think about is management. I want you to think about it, your job. If your boss was treating you, if your boss treated you the way so many parents treat children, how long would you stay in that job? Or if you're the boss and you have employees who are acting the way these children are acting, what can you do? What are the things you can do? And people say, oh, well, we can't spank children anymore, and so our hands are tied. Well, you can't spank employees either, so you have to go to management school and learn how to do something. So there's always a way to work through it if everybody stays in their thinking and works hard at it. So in terms of all of these medicines, the things that we're looking for, if a decision has been made for medicine and it all sounds real good and the judge has signed off, or the parents, if they're available, they've signed off, then we say, okay, well, what are we looking for? Well, you're really looking for pretty substantial improvement. So if I'm going to spend this money and take this medicine, I need to see improvement. And we're looking for improvement in the target symptoms. So if you have children that are on medicine, something you can do to help structure the treatment that they're involved in, you just say, well, what are your target symptoms? What is it that you're working on? What are you hoping the medicine's going to do for you? And they'll say, well, we're just hoping that he'll talk nicer. Well, all right, now what I ask them is, and you can ask them too, well, how would you know if he's talking nicer? Are you counting how many nice things he says to you in a day? So we have to get people to start counting things. What is the behavior you're looking for? I asked some parents yesterday, I said, just let's talk a little bit about tomorrow. I want you to tell me, how much time do you plan to spend tomorrow screaming at your 8-year-old? Okay. Well, any parent's going to say none. Okay, we'll go. Now we have a goal. How many minutes did you spend? Well, he got me to scream at him for a half hour. All right, let's work on that. Let's narrow it down. It won't all go away all at once, but narrow it down. Can I get it down to 24 minutes, 22 minutes, 12 minutes? So we start whittling it away and working down. So you go back and remind them that you're looking for target symptoms. We're looking for improvement in the target symptoms, something that we're counting, something that's easy to measure. And the other thing we're looking for on the other side is we're looking for side effects. The most common side effect of the psychiatric medicines that we see is, again, the most common medicine is going to be the stimulants that are going to be used for treating attention problems. The most common side effect is that it will bother their appetite, cut out their appetite, and it'll bother their sleep. And that's only if they take it too late in the day, typically. And so if it's, and I will tell you, we talk about children and their appetite. In my clinical practice, I've never taken a child off medicine because he stopped eating. If the dose is right, it doesn't bother their appetite that much, and the benefits that they're going to see at school and in their family is so great that it's an easy choice. So watch out for changes in appetite. Sometimes if they're taking medicine, it may keep them up at night, so then that's information that needs to get back to the doctor that's prescribing the medicine. The other side effect of medicines, of many of the medicines that we use in children, is going to have a sedative side effect. Now, that isn't what we wanted it to do. It isn't that we want it to make them so sleepy that they can't move and they can't cuss me out again. So if we don't want the sedation, so you're watching for the sedation, and we don't want it to dull their personality. I mean, parents and teachers don't want children, but people say, well, if you put him on that medicine, he'll be a little robot. Nobody's going to stand for that. You're not going to stand for that. Their teachers don't want that. The parents aren't going to stand for it. But if you're seeing that, then that's information that needs to get back to the doctor. And I encourage you to get information back to the doctor. And sometimes people say, well, I can't get a phone call in, but I'll tell you, if you write it down on a piece of paper and send it in, or if you sent me a letter about a patient of mine, I really have to put that letter in their chart, and I have to say something about that letter. I can't just ignore it. So it will get dealt with in some fashion. So always get people to try to write things down when you have concerns. Some of the medicines have serious long-term side effects. Some of the medicines have effects on the way your body would metabolize sugar. It can elevate cholesterol. But doctors pretty much understand those kind of side effects, and so they will be doing blood tests to monitor for those side effects. And again, if you think about the medicine, which costs a lot of money, and it's potentially causing side effects that require some kind of blood test that costs a lot of money, and that getting your blood drawn, that's going to hurt, and it's going to take another day out of my time to go to the lab to get it drawn. That medicine really needs to be making a big difference, and if it's not making a big difference, then we need to be talking about it. So that pretty much covers what I wanted to say about helpful effects and side effects of medication. And we're kind of getting to the end of this, and let me recap. So I want people to think about psychiatry. In my work as a psychiatrist, I think about some children that have brain problems and some children that are struggling with life event problems. The life event problems, we ought to be looking at what kind of counseling and therapy is going to help. For children that have brain problems, we need to be thinking about, is there a medicine that has some good research and says this is likely going to have a helpful effect for this child. Making that decision requires a very careful, well thought out, good evaluation that leads you to a diagnosis. The diagnosis then is going to lead you into a treatment plan. And I don't want to forget in here at all about the safety plan, making sure that children are going to be safe, that they're not threatening to hurt themselves. We don't need suicides. So once you have a treatment plan, then you're going to have a follow-up plan. And so the child is going, wait a minute, I got ahead of myself. Before I have a treatment plan, but I haven't had anybody agree that we're going to have this treatment plan. So I have to be sure that this child has given assent. Assent is what children give. And where it's appropriate, the parents can give consent. If I can't find parents, then we get authorization from the judge, and there's a process for that, and we've gone through that process. Once everybody's agreed and we're all on the same page, then we're going to move into our treatment plan, and we know what our target symptoms are. We're counting our target symptoms, measuring to check and see if the treatment we've recommended is making a big difference. And if it is, then these children who sadly have had their lives turned upside down, at least they're not suffering unnecessarily, which I think is the purpose of all of our work, or my work as a child psychiatrist, your work as a guardian. As I close, I'm going to put up a slide that has some of the websites that I talked about during my presentation today. They have information. A lot of it is written for people who are providing care to children, some written by psychiatrists, for psychiatrists, or other people involved in treatment, but many of you would be able to understand that. And then a lot of the website, particularly the National Trauma website, has a lot of information that covers all areas and all levels of information. The Florida Mental Health Institute, that will be another one of the contacts that's there. They have information both for people that will be prescribing medication and treating children, as well as information for parents to help them understand if the doctor has made a recommendation or suggested that their child might have a particular condition. I hope all this information will be helpful to you, and again, I want to thank you for the hard work that you do for the children.